This is part 2 on the section regarding venous ulcer and lymphedema management. In the first section, we talked about the pathology of venous insufficiency, the indications of venous insufficiency, the characteristics of venous ulcers, the primary goals for management, primary strategies for management, which of course comes down to compression and elevation. And then we spent time talking about initial therapy, which is always or typically involves application of compression wraps. The use of compression wraps early in therapy allows you to adjust the wrap each time it is applied to fit the patient's leg at that point. Once edema is controlled, once the leg is down to its dry weight, once exudate is controlled, then we typically move ahead to use of compression stockings. So that's what we're going to talk about now. We're going to talk about guidelines for use of compression stockings, alternatives to use of stockings long term, guidelines for topical therapy, and then differential assessment of venous edema versus lymphedema. So of course you've all seen stockings, and you have stockings demonstrated here. They're indicated primarily for long-term therapy, for maintenance therapy. We do not typically use stockings early on for the reasons we've already discussed. Now, the issues with therapeutic support stockings are the things you already know. They work extremely well as long as they're fitted correctly so that they're giving the right amount of compression. The patient wears them consistently, which of course is a huge issue. And they also have to be replaced at regular intervals. So typically, just about the time they get to the point where they're pretty easy to put on and don't feel so tight, it's time to replace them. Now, one of the hard things for patients, you think about the fact that a lot of our patients with venous ulcers are older, a lot of them are overweight, and so it may be hard for them to get stockings on. And one of our goals as providers is to assure that we have identified a stocking that the patient can use effectively, that we have helped that patient determine a technique that is pretty easy for them to get the stocking on. In a lot of clinics, they find that if they bring the patient back at regular intervals to check with them on stocking use, that's very helpful. So let's say you've been working with the patient, you've had them in wraps. Now they're down to dry weight, the edema is eliminated, the exudate's under control. The advantage of crossing the patient over to a compression stocking at that point is that it gives you several weeks before the ulcer is completely healed to work with the patient on stocking application to reinforce the importance of consistent stocking use. Then even after the ulcer is healed, you probably want to bring that patient back at 3 to 6 month intervals to reinforce to the patient the fact that even though the ulcer is healed, the underlying venous insufficiency is still there, and that he or she needs to be wearing the stocking to control edema and to prevent recurrence. Now we're going to show you some of the things that are out there to make it a little bit easier for patients. Jobst has a system called the Ulcer Care System, and it has this silky liner, so you pull the silky liner on, that's very easy to do. And then the stocking has a zipper that is offset so that it won't be over any bony prominences. But you can see that the combination of the silky liner and the zipper makes it much easier to pull the stocking on and then to pull the zipper up. So that's one option. Another option, a lot of companies have a silky footie or a little legging that's kind of like parachute type material, and you put this over the leg and then you pull the stocking over this and then you pull this off. The poor man's version of this is the plastic, those plastic liners for kitchen garbage cans. If your patient is wearing an open-toe stocking, they can pull on that trash bag, which gives you a very slick surface, makes it much easier to pull the stocking up and over. Then you can hang on to the stocking at the top and pull the trash bag out from the bottom. So you can do the commercial version or you can do the poor man's version. There's also something called a stocking donor that mimics the leg. So you put it in front of the patient with the curve facing them. You take the stocking just as it would go. You push the stocking down over this little frame until the heel pocket is exposed. And once the heel pocket's exposed, then it's very easy for the patient or the caregiver to slide the foot down into the stocking, and of course getting it up over the heel is one of the hardest parts. But once I have the heel pocket exposed, I can just slide the leg into it or the foot into it, and then I can just pull it up. Makes it very easy. I got this for my dad when he was working with my mom. He's like, "Where was that?" 2 months ago. And then in just a minute, I'm going to show you an alternative to the use of stockings tube grip. Okay, so you want to work with your patient on stockings. You want to know that there are multiple donning aids out there. You want to work with them to find what works best for them. Now, what if you have a patient and you've worked with that patient and he or she just can't get those stockings on? They have severe arthritis, they have something else going on that makes it impossible for them to adequately grip and pull the stocking. Well, there are Velcro type devices. These are considered compression orthotics. This happens to be the Ferro Wrap. And you can see it just closes with Velcro. So it's much easier for some patients to use a Velcro device, and when it's correctly sized and you just wrap it around and secure it, you get therapeutic level compression. One of the disadvantages is that those are more costly than stockings, and of course they're not covered by most insurance companies. But you're going to have a wide variety of patients. So for some patients, the big issue is cost, and you're trying to help them come up with the most cost-effective alternative. For other patients, it's ease of use. Maybe they have really good insurance coverage, or they can afford some out-of-pocket costs, but they need something that's simple for them. So you want to know about the orthotics. What about ACE bandages? A lot of people think, well, I'll just get an ACE bandage, or I already have ACE bandages. Why don't I just wrap my leg with ACE bandages? ACE bandages are not a good option for compression. They're not a good alternative to stockings or to your orthotics or even to tube grip, which I'm going to come to in just a minute, because they're very long stretch. They have a lot of give. Probably most of you have had the experience of wrapping a patient's leg with an ACE wrap, thinking it looked pretty good, having the patient get up and walk around, and the whole thing falls down. And that's because there's so much stretch in an ACE bandage. So you think about what you want to provide. You want to provide support to the calf muscle and to the calf muscle pump. So that means you don't want give. You don't want that ACE wrap stretching when the patient's walking. You want firm support. So ACE bandages are not a good choice. They do not give therapeutic level compression. Are they better than nothing? Probably, but that's just about the only thing they're better than, is nothing. One other thing I wanted to mention is tube grip. A lot of you have access to tube grip. Several companies make this. It's very much like stockinette. It comes in all different sizes. If it is sized correctly, based on calf muscle diameter, each layer of tube grip gives you 10 millimeters of mercury. So if you have a patient who's having a very hard time getting a stocking on, if they can get on even one layer of tube grip, they get 10 millimeters of mercury compression, which is not what you want, but is better than nothing. Most patients can get on at least 2 layers. So you size it so that it's twice as long as the distance from the base of the toes to the knee. They put on the first layer, they double it back, they pull on the second layer. So with each layer, they're only pulling against 10 millimeters of mercury, but the end result is 20 millimeters of mercury compression. Again, not your desired level. You'd like 30 to 40, but 20 is much better than nothing. And almost all of our patients can get tube grip on, and it's inexpensive. They can hand wash it. and reuse it multiple times. So think about Tubigrip as an alternative for patients who have a hard time with stockings and who can't afford orthotics. Now, we talked a little bit about dynamic compression. We're not going to spend a lot of time on this. This is considered second-line therapy for patients with venous ulcers. It's not covered by most insurance companies, including Medicare, unless the patient has failed primary compression therapy with wraps or stockings. But you can see the advantage of dynamic compression. When it cycles on, the sleeve compresses. It compresses the calf muscle pump. It propels venous blood back to the heart. Then it relaxes to allow arterial inflow. Compresses to push venous blood back to the heart. Relaxes to allow arterial inflow. So one of the advantages of dynamic compression therapy is that, first of all, if you have a patient who doesn't tolerate sustained compression well or can only tolerate low-level sustained compression, if you could add dynamic compression therapy 2 to 3 times a day for an hour each, you can most of the time help to keep that edema under control, maintain adequate venous return, and get venous ulcers to heal. The other patient who's going to benefit specifically from dynamic compression therapy is a patient who has mixed arterial venous disease, because it does not provide sustained compression, so does not interfere with arterial inflow. But when it cycles, it effectively empties the venous bed. That actually invites arterial flow in once the pump relaxes. So you can see where it squeezes, it evacuates the venous blood, it relaxes, allowing arterial inflow, squeezes, pushes venous blood out, relaxes, invites arterial flow in. Now let's talk about topical therapy. Topical therapy, of course, is going to go back to the principles we've already talked about. You want to manage your exudate. You want to obtain a moist wound surface. You want to protect the surrounding skin from maceration. But one thing you have to think about with venous ulcers is, because they're very, very wet, and because almost always we have the patient in a compression wrap that only gets changed once or twice a week, it's very important to control your bacterial loads. It's very common to find that venous ulcers become critically colonized, not uncommon at all to find them with biofilm formation. Makes sense when you think very wet wound, infrequent dressing changes, essentially an occlusive environment because you've got them wrapped in a compression wrap. So almost always you're going to be using antimicrobial dressings for your patients with venous ulcers. If they actually have a biofilm, as you know, you need to gently remove the biofilm mechanically, because most of your antimicrobial agents do not penetrate biofilm effectively. So if I was dealing with this wound on top, I would flush the wound thoroughly. I would take either damp gauze or a blunt curette and gently scoop off all of that yellow tissue that probably represents biofilm. Irrigate again. Protect the surrounding skin either with a moisture barrier ointment or with a skin sealant. And then apply an absorptive antimicrobial dressing. It could be a silver alginate, it could be a silver hydrofiber, it could be an antimicrobial foam. Foams come with a number of options, so you could get a silver-based foam, you could get a foam with PHMB, you could get the hydrophilic blue foam. So lots of options for controlling your bacterial loads while also controlling your exudate. Now, another common problem with venous ulcers is this venous dermatitis, and it's pretty easy to recognize in that it involves the entire sock area of the leg. There's usually circumferential erythema. The patient usually complains of intense itching. The surface of the skin is usually kind of bumpy and maybe weepy. Very important to control this itching and this inflammation. so that the patient can leave a compression wrap on and to control the inflammation so the wound can progress toward healing. Most of the time you have to use low-level steroids. Kenalog spray is a great choice, triamcinolone. If you can't get that, any of your low potency or mid potency steroids, your creams. You would usually not use an ointment because it contributes to a moist environment, so usually you would use a cream, massage it in well, reapply each time you reapply the compression wrap, or if the patient's in stockings or tuba grip, reapply once or twice a day, depending on manufacturer's recommendations. Once you get the dermatitis under control, you can cross them over to a moisture barrier that prevents contact between the exudate and the skin to prevent recurrence. Now, we've already said that patients with venous disease have to be educated regarding the need for long-term management. They have to know that the ulcer is the symptom of the underlying disease process. The ulcer is not the entire problem. So they have to know that long-term they're going to need to use compression. Typically stockings, possibly tuba grip, possibly an orthotic. So we spend a lot of time educating them about that. And then you're going to have a small group of your venous ulcers that might be non-healing. They don't respond initially to therapy, and you have to think, what's going on here? First of all, go back, make sure that you do have therapeutic level compression. Make sure that the wrap is being applied correctly if you're using wraps. We know that a common mistake made by nurses is not to provide enough compression. They're so afraid they're going to get that wrap too tight, that they're going to cause a problem that they don't get it tight enough. They're not providing therapeutic level compression. So if your patient's in a wrap, go back, look at who's applying the wrap, make sure they're applying the wrap correctly and that they're getting therapeutic level compression. If the patient's wearing stockings or tuba grip, go back and make sure that first of all it's sized correctly, that the stockings are not old, that they have new stockings or relatively new stockings. Talk to the patient about how many hours a day they're wearing the stockings, because sometimes they're not wearing them all day long, or they're only wearing them like when they go out, but they're not wearing them around the house, or they're wearing them when they come to see you, but not the rest of the time. Go back to that old principle that any compression on the leg is better than 30 millimeters of mercury compression in the drawer. Work with your patient. Talk to them about how important compression therapy is to getting their wound to heal. Talk to them about what problems they're having with compression therapy. Work with them to find something that will be effective and will be comfortable enough that they can maintain compliance with that program. Also remember that any chronic wound can deteriorate into a malignancy. With venous ulcers, they sometimes deteriorate into either squamous cell carcinomas or basal cell carcinomas. Basal cell carcinomas are particularly easy to miss because they masquerade as hypertrophic granulation tissue. So if you have a venous ulcer with hypertrophic granulation tissue, you've treated it with silver nitrate, it keeps coming back, you need to biopsy that wound. If you have a venous ulcer and you can't figure out why it's not progressing, you need to biopsy the wound. And finally, if you have a venous ulcer that's not progressing, you've ruled out everything else, go back to what we talked about earlier. Some of these patients desperately need surgical intervention to obliterate problematic perforator veins so that the system becomes more competent, more efficient, and so that you can get that ulcer to heal. Now we're going to talk a little bit about lymphedema. Before we really get into lymphedema, let me first of all just clarify that lymphedema management is not within our scope of practice. Primary lymphedema management requires a whole nother skill set. Therapists who do lymphedema management go for a 2 to 3 month course to learn a technique called manual lymphatic drainage, which is a very specific type of massage that mobilizes lymphatic fluid out of the tissues and back into the bloodstream. But it's not something that you can just say, oh, they need a massage and start doing it. It is a very specific technique requiring very controlled amounts of pressure to the underlying tissue. And we'll go into it a little bit more as we get into lymphedema management. But first I want to just reiterate, that is not within your scope of practice. The reason we go over lymphedema management or the basics of lymphedema management is because you need to be very aware of the difference between lymphedema and venous edema. You need to identify patients who have lymphedema, and you need to make sure that they get referred to a lymphedema treatment center. You know how it is. If you're in an outpatient wound center, or if you're in the hospital and you do wound care, or you're in long-term care and you do wound care, any patient with a skin problem gets referred to you. Any patient with an ulcer gets referred to you. A lot of your lymphedema patients will have cracks in the skin. They will have massive weeping of fluid. They are very prone to ulcer formations, so they show up on your consult list. They show up in your clinic. You want to be able to differentiate between patients who have venous insufficiency and venous ulcers. Those patients you're very well equipped to manage. Patients with lymphedema and ulcers secondary to the lymphedema, you can manage the ulcers, but you need assistance in managing the underlying lymphedema. So let's go over why that's true. Let's go over why lymphedema is so different and why we can't just manage it exactly the same. So it goes back to the lymphatic system, and whenever you look at a diagram, the circulatory system, it will always show the arterial side of the capillary bed, the venous side. So you've got the arterial system, the venous system. And you've also got the lymphatic system. Now for me, when I was studying A&P, the vascular system, I was always very focused on the arterial system and the venous system and not paying so much attention to the lymphatic system. The lymphatic system is an important system, because what it does is it plays the scavenger role. And let me explain why that's important. Every day as blood is pumped through the vascular tree, comes from the arterial side under pressure into the capillary bed. On the arterial side of the capillary bed, a lot of fluid is forced out into the surrounding tissue. That plasma is oxygen rich, so it takes oxygen to the tissues, takes nutrients to the tissues. But in the process of forcing fluid out into the tissues, some of the plasma proteins are also forced out into the tissues. Now on the venous side of the capillary bed, the pressures are much lower within the capillary, so most of the fluid moves out of the tissues back into the capillary bed. On the arterial side, pressures are higher within the capillary bed than the tissues, so fluid moves out. On the venous side, pressures are higher in the tissues than in the capillary bed, fluid moves back. But here's the problem. Not all of the fluid moves back. And most specifically, those plasma proteins, those are big molecules, so they're forced out on the arterial side under pressure. But there's not enough tissue pressure to force them back in on the venous side, so they tend to get trapped in the tissues. Now, every day, throughout the day, little bits of fluid get left behind, some plasma proteins get left behind. Altogether, the amount of fluid that gets left behind every day is about 2 liters. Well, you can see that would, over time, become very, very significant. That's where the lymphatics come in. The lymphatic vessels are open-ended, so it's very easy for those big plasma proteins to be picked up by the lymphatics. So both the fluid and those big proteins are picked up by the lymphatics. The fluid goes through the lymph nodes, of course, where bacteria are destroyed. Hopefully any malignant cells are trapped. And then look what happens. It goes right back into the venous system. So it's returned to the circulation. That's why we say it serves the role as scavenger. Lymphedema is much less common than venous edema because we have so much redundancy in the lymphatic system. Our capacity for lymph transport is 10 times greater than our lymph production every day. So we tend to produce about 2 liters, and we could actually transport 20 liters. So why do people get lymphedema? Well, some people are congenitally predisposed because of fewer lymphatics. We don't see many of those. We see patients who fall into the second and third category. Patients who have radical cancer surgery. So think about the fact that originally women with breast cancer underwent radical mastectomy that included stripping out all of the lymph nodes in the axillary area. And it was very, very common to see women with lymphedema following mastectomy. It was a common complication. There was routine care and assessment related to lymphedema formation. And many women ended up having to wear very tight sleeves and use pumps to keep the lymphedema under control. Today, cancer surgery involves much less lymphatic destruction. Now it's very common for surgeons to instill a dye into the tumor bed so that they can clearly identify which lymph nodes are involved in draining fluid from that tumor bed. And so they can be very selective in the lymph nodes they remove. That means they cause much less damage to the lymphatic system, and the patient's much lower risk for lymphedema. So do we sometimes see patients with lymphedema following radical cancer surgery? Yes, but it's much less common in the past. However, look at the next reason, chronic venous disease. We know that with chronic venous insufficiency, recurrent ulcer formation, one of the things that happens is you get a lot of scar tissue out in the soft tissue, and that scar tissue obliterates the lymphatic channels and interferes with the lymphatic's ability to pick up the fluid, pick up the proteins, and return it to the venous system. So we might start out with a patient who has venous insufficiency, and over time, that patient might develop lymphedema. So you just want to be aware that lymphedema is a potential complication of chronic venous insufficiency, especially if that chronic venous insufficiency is poorly managed. In third world countries, the most common reason for lymphedema is filariasis. That's a parasite infection that targets the lymphatics, destroys the lymphatics. And you've probably all seen pictures of people who have massive enlargement of the legs or the arms, known as elephantiasis. Now, I wanted to just reiterate that one of the big differences between lymphedema and venous edema is the fact that with venous edema, you're pretty much dealing with water and salt. And so it's pretty easy to push that fluid out of the tissues and back into the bloodstream just by applying a compression wrap or a compression stocking. But remember, with lymphedema, you've got protein-rich fluid, and it's very hard to force those proteins back through the small pores in the capillary bed to get those proteins back into the bloodstream. So it's much harder to mobilize lymphedema fluid than it is to mobilize the fluid associated with venous insufficiency. Now, there's actually 3 levels of lymphedema: reversible, spontaneously irreversible, and then lymphostatic elephantiasis. Reversible is the early phase of lymphedema, and at this point, the lymphedema will respond at least partially to elevation and compression. So if you put this patient with reversible lymphedema, if you put that patient in, say, a 2-layer, 3-layer, or 4-layer wrap, would they respond? Yes, they would usually respond. But here's the problem. If you fail to include the toes in that wrap, the toes would remain very edematous, because lymphedema is going to be toes to groin whereas venous edema is typically ankles to knee. So when you're wrapping someone with lymphedema, you're wrapping toes, at least toes to knee, and sometimes toes to groin. I want you to notice that the toes are very much involved here, okay? So instead of edema that begins primarily at the ankle, goes to the knee, now you have significant edema involving the foot and the toes. They start to look like little sausage toes. You lose the ability to pinch the skin at the base of the toe because there's too much fluid out of the tissues. So the clinical indicators, you have edema that's usually still pitting, but it extends into the foot and the toes, may extend to the groin. At this point, you don't have any major changes in the skin and soft tissues. It's just a difference in the distribution of the edema fluid and also some difference in responsiveness. So you're not going to get as rapid a response to your compression therapy and your elevation as you do with venous edema because you're dealing with a different type of fluid. Now phase 2 is known as spontaneously irreversible edema. At this point, your edema typically becomes brawny or non-pitting so that it feels like you're pressing against a tree trunk. You have major changes in the skin and the soft tissue. So you start to develop these little papillomas or little tiny outgrowths in the skin that makes the tissue look almost cobblestone, has a cobblestone appearance. Very common to get skin breakdown, ulceration here, and you always have a positive stemmer sign. And a positive stemmer sign means that if you think of these as my toes, and so this is the base of my toes on the top of the foot, when you go to pinch the skin at the base of the second toe, you can't do it because there's too much fluid in the tissue. Now, if you try to pinch the skin at the base of your second toe, yes, you're going to be able to pinch that skin because you don't have a lot of fluid there. If you can't do that, that's known as a positive stemmer sign. But the changes in the skin and soft tissue are probably the most dramatic change here. Typically, there's no response to elevation at this point. There's too much fluid out in the tissues, too many of those plasma proteins. They're not going to just drift back into the capillary bed as a result of elevation. Compression may help some. So sometimes patients do respond to your 2-layer, 3-layer, 4-layer compression wrap, but not to the level that they would respond if it was venous edema or if it was phase 1, stage 1 of lymphedema. So response to compression is variable. Now stage 3 is the most severe. This is lymphostatic elephantiasis. This is where you have massive changes in the skin and soft tissue, severe papillomatosis, all of these little nodules on the surface of the skin, marked cobblestone appearance to the skin. A lot of times there's enough depth between the little papillomas that they tend to trap bacteria and fluids so that there's kind of a chronic odor. There might be kind of some chronic skin infections. It's a challenge just to maintain normal hygiene. Very common to see ulcerations at this point because you've got so many changes in the skin and soft tissue, starts to compromise perfusion. At this point, elevation will do nothing and compression therapy typically does nothing. They definitely need to be referred to a lymphedema treatment center so they can get complex decongestive physiotherapy. So if you look at your handout, complex decongestive physiotherapy usually involves several things. First of all, it involves manual lymphatic drainage, and that's what we talked about earlier, that specialized technique that mobilizes lymphatic fluid out of the tissues and back into the bloodstream. Here's how it's done, just in general terms. First of all, the patient has to be willing to come into the clinic for treatments that last from 1 to 2 hours. They have to be willing to come in either every day, 5 days a week, or at least 2 or 3 days a week until the lymphatic fluid has all been mobilized, at which point they can be maintained with very snug, inelastic compression garments. But what I want you to think about is that the lymphatic system is essentially a quadrant system. So your right leg and the right lower abdomen is one quadrant, left leg, left lower abdomen, another quadrant, then upper abdomen, right arm, and neck, third quadrant, fourth quadrant. So let's say it's my right leg that's involved with lymphedema. They can't just start at the toes and start to try to move past all that fluid. What they have to do, they'll start with this very specialized massage technique in the lower abdomen to mobilize fluid out of these channels, open up these channels. Then they'll go to the top of the leg. Then they'll go a little bit more distal, a little bit more distal. So they start proximally and gradually go distally, mobilizing the fluid. In between treatments, they apply very snug compression garments, typically 40 to 50 millimeters of mercury compression. Once they get all the fluid mobilized and the patient's maintained in those very snug, inelastic compression garments. They also teach the patient to do exercises, to use the calf muscle pump and everything to keep fluid flowing. And it's critical for them to provide meticulous skin care. So what do we always teach our patients post-mastectomy? We know that their lymphatic system is damaged, that they're less able to manage any minor breaks in the skin that allow bacterial invasions. We tell them don't allow anybody to do venipunctures on the affected arm. We know that tight pressure, localized pressure like with a blood pressure cuff can cause further damage to the lymphatics. So we tell them don't let anybody take your blood pressure on this arm. Same thing for the patient with lymphedema involving lower extremities. We have to teach them meticulous skin care. In some centers, they give the patients prescriptions for antibiotics, and they tell them if you start to see any signs of cellulitis, get this filled, start taking the antibiotic, make an appointment. Okay, I'm going to go back sorry. Because we can't do this complex therapy, that's not in our skill set. Even if you learn to do it, reimbursement for complex decongestive physiotherapy is limited to therapists, physical therapists, occupational therapists, massage therapists who have taken this course and have that skill set. So if you are in an outpatient clinic and you're seeing patients with lymphedema, you need to know who in your area is doing lymphedema management so that when you see a patient with lymphedema, you can make sure they get appropriate referrals. If you don't know right now, you can you can go to Google and you can type in lymphedema treatment centers and your zip code. And you'll start to get a list of centers that provide lymphedema management. Back to what I want you to be able to do, accurately differentiate between venous edema and lymphedema. Venous edema location is going to be ankles to knees, water and sodium-based fluid, great response to elevation and compression. Lymphedema is protein-based fluid. The distribution is toes to groin. They'll have that positive Stilmer sign. They'll get major changes in the skin and soft tissue, those papillomas. And as the disease process progresses, there's less and less response to elevation and to compression. Okay, thank you very much.